Fine. We'll be talking about scintigraphy as a functional imaging modality, followed by details, indications, where it is used, how does it compare with the other modalities available for imaging, and then we'll come on to some representative or interesting scans, relevant MPI terms as we see the scans. This talk will be followed by another talk where we will be seeing some myocardial perfusion scans. It will be delivered by my colleague consultant at the Nuclear Cardiology Department of AFIC and IHD, Colonel Inam Nouman. So I'll see if I have time. I'll show you some scans. Otherwise, he'll be showing you the scans, and I'll do the talk part first. Popular nuclear cardiology imaging studies, as you all know, include radionuclide ventriculography, myocardial perfusion scan, viability assessment, myocardial infarction or nerve innervation imaging, and shunt studies. Of these, what are mostly done in AFIC and IHD and elsewhere in Pakistan in most of the departments are the myocardial perfusion scans for ischemia and viability assessment. Now, why nuclear cardiology? The imaging studies have stood the test of time and survived for more than 4 decades due to non-availability of similar information from other modalities, non-invasiveness, cost-effectiveness, reliable published studies supporting usefulness, and ability to visualize changes in hemodynamics and cellular metabolism with assessment of effectiveness of treatment. Now, our focus today will be, like we've already discussed, on MPS or MPI in ischemia and viability, its comparison with angiography. Let's talk of this first. Is it justified? We were just now talking about CT angio, which is another form of luminography, like the conventional coronary angiography. Mostly, myocardial perfusion imaging is compared with the results of an angiogram, be it a CT angiogram or a conventional angiogram. The issue with this type of comparison is that it is only a visualization of the lumen of coronary vessels of the larger and medium size when we are doing an angiogram or a CT angiogram. But when we are actually doing a myocardial perfusion scan, we are looking at the perfusion of the myocardium itself, which is definitely not supplied directly by the larger or the medium sized vessels, but by beyond smaller size arterioles and capillaries. So, can better patient management decisions be taken with the help of nuclear cardiology techniques? Yes, definitely. For example, the patient who comes to you with complaints of ischemia. Most of the time, ischemia which is precipitated by exertion. There is no test which is exerting the patient and watching the status of the vasculature or the status of the myocardial perfusion. So you can take effective management decisions by looking at if your treatment is effective and it is definitely visible on a myocardial perfusion scan through absence of ischemia even during stress. Now, other options, they may be, like we said, CT coronary angiogram, fraction flow reserve measurement, stress echo. Nowadays, cardiac MR, very popular, available in a few centers with limited expertise. But whosoever has it, there are enough studies to claim many things about CMR these days. So where do we stand when we talk of ischemia and viability through these modalities or nuclear cardiology? What are the true and perceived limitations in these cases? We start with ETT, the conventional screening modality. It's low cost, limited or no preparation, and this has made it a very popular non-invasive test for diagnosis and follow-up ischemic heart disease patients. Similarly, multi-slice CTCA is again considered non-invasive, is preferably advised these days, but is poor at predicting ischemia. It can only look at the blood vessels and talk of the blood vessels. There are occasions when we see that there is an occlusion, even a subtotal or a total occlusion, which does not cause ischemia because of collateral supply or because of other reasons. So to arrive at a conclusion, that the patient needs an intervention just because the CT angio is abnormal or the angiogram is abnormal is perhaps a little, in my opinion, non-professional. Again, as it was mentioned by the previous speaker, there are radiation and contrast related effects of CTCA or CA. Now this is something interesting. Actually, more of CT angiography has led to more referrals to my department, because you come up with incidental findings of subcritical coronary artery disease, and the patient needs to be evaluated if this subcritical disease is actually causing ischemia or not, or if there are lesions, what is the functional significance of such lesions in case of a particular patient. Cost effectiveness studies, meta-analysis available, many studies have been done over multiple years, and they all say that diagnostic approaches utilizing ETT or MPS have no cost difference in intermediate or high likelihood patients with suspected coronary artery disease. ETT, however, was found economical in low likelihood cases. We all know that the best results are obtained in intermediate likelihood patients when they are subjected to any test. If you use a high likelihood population, you are likely to miss patients. And if you use a low likelihood population, you are likely to put in more false positives. There are studies which document that myocardial perfusion imaging has the ability to prevent downstream testing and decrease costs, and it may also avoid invasive tests like coronary angiography. I'll try to rush because I think I'm running short of time. So diagnosis and future risk, as she was talking of risk stratification, myocardial perfusion imaging is very important in risk stratifying patients, as well as looking at the effectiveness of the current treatment. Even the previous treatment, if revascularization was done, how good or bad is the patient now? Like we discussed a short while back, if the patient has had PCI, for example, and is coming back with chest pain, it's not necessary to expose the patient to the contrast again or to the radiation again of the magnitude of a CT angiogram or an angiogram. We can instead go for a myocardial perfusion imaging scan, and we can come up with the actual status of perfusion of the myocardium. Similarly, there are many patients where the patient has had an event which has led to a subendocardial scar, at times a transmural MI also, which is small enough, not picked up elsewhere. There's no good wall motion abnormality visible, and stunned and hibernating myocardium is definitely not visible through other modalities. So all these places, myocardial perfusion imaging comes to the help of the cardiologists and cardiac surgeons. Wall motion can be looked at through gated myocardial perfusion scans. Gated images give you a good reproducibility and are reliable for interpretation, especially when compared with other modalities which are operator dependent, be it echo or stress echo, whatever. Let's come to the indications for stabilization. Positive ETT without symptoms. Similar can be positive CTCA without symptoms. Screening of high-risk asymptomatic population, we are frequently doing it. Assessment of patients who cannot undergo ETT. Another population which comes to us, we do pharmacological stress using adenosine, or there are centers which are using percentine, and we come up with the results. Those patients who have abnormal resting ECGs, like, for example, left bundle branch block or other conduction abnormalities, where an ETT can also be non-diagnostic. Assessment of functional importance of known coronary artery disease, assessment of therapeutic benefit. We've already kind of discussed these things. This culprit lesion we all know about. At times there are 2 or 3 vessels involved. We want to know which one is causing the ischemia or which one is the culprit, so that we tackle it accordingly. Risk stratification we've talked about, and demonstration of ischemia in patients with angiographically normal coronary artery disease. There may be syndrome X, there is endothelial dysfunction. These things people don't talk about. They are not even taught in training, unfortunately. And most of the people who go through FCPS exam also are found to know little about these things. But these are very important from the patient's perspective, especially. This is post PCI, earlier on or later. This is post cabbage. These are other indications which can be after PCI or after cabbage or after either. These are the different patterns of myocardial perfusion images, scintigraphic patterns due to different vessel involvement. We all know these things so I'll not try to take much time here. Knowledgeable people sitting in the audience. Now I'll dwell on this for a short while. These are the frequent problems which the cardiologists or the cardiac surgeons feel are there with myocardial perfusion imaging. Real scintigraphic defects or true false positives. Now, real scintigraphic defects can occur because of coronary anomalies. They can be a vasospasm. So many times there is vasospasm on angiogram, and the patient is diagnosed as somebody with a lesion, but actually there is no lesion. It was just that vasospasm, the transient phase that the patient was passing through. So the patient comes to us, for example, he or she has been referred for myocardial perfusion scan, and it's found that it's perfectly normal. So there is a tussle going on between the cardiologist and the nuclear cardiologist that the angiogram had a lesion. So how come the scan is normal? Anyway, so the real scintigraphic defects can occur through these mechanisms. They can be microvascular disease, they can be cardiomyopathies, conduction abnormalities like Dr. Tahira was discussing. Cardiomyopathies, conduction abnormalities, and post-COVID these days we are seeing quite a few of these things, plus regional wall motion abnormalities which don't have any other basis. Then recanalized coronary occlusion is another fact which keeps happening. True false positives are due to regional photon attenuation, for example, breast attenuation artifact in females, poor quality images or technique, and post-test referral bias. False negatives can again be due to real scan interpretation problems, and they can be true false negatives. The real scan interpretation problems can be due to inadequate exercise or pharmacological stress, which is again a fact, keeps happening all the time because it needs continuous encouragement to the patient and motivation to the staff to carry out stress properly. Administration of anti-ischemic medication. Many a times a cardiologist wants the patient to have a scan with the medication, and there are others who want the medication to be stopped. So it is not adequately conveyed to the nuclear cardiologist as we are often doing the scans. We don't know if we have to do the scan without medication or with medication. So most of the time we are stopping the medication and then doing the scan. Especially those who are doing ETT, physical stress, they would like the heart rate to climb, and they ask the patient to stop beta blockers and come for the scan. At least for 24 to 48 hours, they stop the beta blocker. Then there is overlap or collateral circulation, incorrect interpretation, again a problem. We don't have that much expertise in the country, not many people teaching, not many people learning. Balanced hypoperfusion, that's very popular, but I think it's not that common as its popularity would convey. Again, true false positives can be due to poor quality images or technique, hypoperfusion in attenuated segments, which may be missed. And if we're talking of a thallium scan, which is very rare these days due to the cost of thallium, delay in acquiring stress images. In a nutshell, myocardial perfusion imaging is an appropriate modality for the diagnosis and follow-up of ischemic heart disease in silent or overt ischemia, and is valuable in documenting the patient risk profile and choosing between medical management and surgical intervention options. I think I've taken a lot of time. I leave the cases to Colonel Inam. And how much time do I have? I think I've exceeded my time. Thank you very much. If there are any questions, only one or two. And then I'll be in the panel so we can discuss this later. Yes, ma'am.
Sir, you mentioned the post-test referral bias. I would like your comments on that.
That's a long topic. Let's leave it for the end of the session,
Right.
I think. Because generally what happens is that, like I said, you do a test, you have an idea that this patient has this. And with that idea, the patient is referred to another consultant, maybe another modality. So that consultant gets biased and this consultant gets biased. So ultimately, the patient, if we are not trying to understand each other in the correct way and we do not have a fair idea of what each of us can tell the other person, the patient doesn't get the benefit.
And then